Okay, we're recording live, so don't say anything bad or we'll get reported again. So we're going to talk about kind of the flow of things through the PACU. Some people may be familiar with it, some people may not. I will tell you there's quite a bit of variability from one place to another, so some things may not apply when you get to clinicals, but it kind of gives you an overview of how things work. We're also going to talk about the PACU and kind of how things go from their side of things, and then stuff we can do to kind of streamline the transition from one to the other. And then, like I said, we're going to finish up with kind of some unintended consequences of anesthesia. If you're looking for standards for PACU, this is it. The reason I put this up here is because depending on the setting, you may not have a formal PACU. So, say for instance, you're doing dental anesthesia or plastics in something more of like an office based setting, you're still held to the same standards as somebody that's in a hospital. So, don't feel like just because you're in a different environment, your accepted standards of care are a little bit less. So some of these are kind of vague, and you'll figure that out as we work through it. Anybody that's received general anesthesia, regional anesthesia, or MAC shall receive appropriate post anesthesia management. That sounds really important, but it's also very vague. So what is appropriate? It varies from one person to the next. A patient transported to the PACU shall be accompanied by a member of the anesthesia team who's knowledgeable about the patient. So this really comes into play in some of those office-based settings. You can't just stay in the room and let the nurse transport the patient. It needs to be somebody from the anesthesia team. So CRNA, anesthesiologist. And while you're doing that, you have to be continually evaluating, treating the patient during transport with monitoring and support. So monitoring and support can mean many different things. For instance, if you have somebody who's going back to the ICU, you probably are going to keep them on the cardiac monitor and check their blood pressure, pulse ox, that sort of thing. On the other hand, most of our patients, when they're going to PACU, are going to be off all mechanical monitors and be more dependent on our observation skills. So I'm looking at the patient's face mask to see if it's foggy. I'm looking at their color. I can check a pulse if need be. I'm probably not going to continually monitor them with cardiovascular devices. When you get to the PACU, the patient's got to be reevaluated, and you have to provide report to the PACU RN. RN is kind of a key thing there. They're recognized as being a member of the anesthesia team from that perspective, but not actually providing the care. So if you're taking patients to, say, a plastic center, you can't hand off the care of that patient to a medical assistant. Some places in some states will accept RN, but it's kind of iffy. So what you'll see in a lot of those settings is that you ultimately remain responsible for that patient and thus can't start another case until you've kind of completed the anesthesia monitoring of that patient. Patient's condition shall be evaluated continually in the PACU. That's kind of a vague statement. We'll talk about those things a little bit more in a minute as far as like how they monitor and time intervals and stuff like that. A physician is responsible for the discharge of a patient from the PACU. Now, you notice it says a physician is responsible. It does not say an anesthesiologist is responsible. So if you're working in a solo practice or someplace where there's not an anesthesiologist, it'll be the surgeon that ultimately discharges them from the PACU. Now, you will be the one that ends their anesthesia care, but as far as the discharge, it's got to be done by a physician. There are some variations to that, but that's pretty common. So let's go back and figure out where PACUs came from. Back in 100 years ago, there were a couple of facilities that started opening PACUs because they realized that a lot of times people died in the PACU because they weren't being appropriately monitored. Just like everything else, conflict kind of changes medical care. So after people came back from World War II, we started seeing more and more PACUs because the military had kind of recognized that that was a critical time period for patients. And when you guys get to clinicals, you'll really see that it is. It's a very critical juncture for those patients. So after that, somebody did a study and they figured out that about 50% of those patients didn't need to die, which is really an opportunity for improvement. And then in the late 40s, PACU care became a standard. So, what do you see as far as the staff in a PACU? It really varies from one place to another. I think the most common setup you see is a series of registered nurses, usually either in a 1-to-1 or 2-to-1 ratio, caring for patients. There may be a respiratory therapist that's assigned to PACU, but usually they just kind of float through and help out with things. You may see some facilities, patients come out to PACU on ventilators. Sometimes they come out with existing airways like an LMA, and they get extubated there. In those facilities, it's somewhat common to have an RT be a little bit more present. Otherwise, what you usually see is that there's not an RT that's there, but say you need to have somebody on a wake up vent or something like that, they'll pass through and take care of that. There's usually a series of setups that are kind of designed for somebody to provide anesthesia coverage to the PACU. Because remember, this is ultimately like our ICU, for lack of a better word. So it may be that whoever's running the board or whoever's in charge is responsible for covering PACU. Some places, everybody takes care of their own patients in PACU. So, for instance, you may write the orders, and then if there's a problem, they call you. Now, if you're already in another case, obviously you can't stop what you're doing to intervene with that. But you may do the initial management of it, and then you may call a colleague to go take care of it. Other places, it's the intensivist or the hospitalist that takes care of those patients. And then ultimately, if they're admitted from the PACU to the hospital without really that being planned, the intensivist or the hospital list becomes involved. So this is where things kind of really deviate. Where is the PACU in your hospital? We try and put it as close to the operating room as possible, but sometimes it doesn't work out that way. You'll see a lot of times as hospitals build and grow, things get further and further away from where they originally were. The exception to that is like if you see that somebody builds like a whole new surgical tower, then usually things kind of reset and start back where they were. But going to the PACU may be as simple as going across the hall, or it may be, half mile some places. And I know that sounds crazy, but it's real. Especially if you think about some of the offsite locations like endoscopy, IR, or cath lab. Sometimes those have their own PACU. Sometimes those PACUs will only take patients that have gone under sedation. So if you have to perform a general anesthetic, you may have to take them to the main OR PACU. So just be mindful of that. And that really comes into play when you think about your anesthetic, but it also thinks about the complications that you come into. Maybe it's not common practice to transport patients on oxygen, but you've got to take them a half mile. Probably want to make sure you have oxygen with them. Do I need to take an ambu bag with every patient? Probably not if I'm going across the hallway, but if I'm going a long way, it's another story. Think about emergency medications and complications you can kind of encounter in between. Monitoring, as we talked about earlier, it may be very basic. Or as you kind of increase the distances or the complexities of the patients, you may need to add something else. There's a lot of facilities that will use like a travel pulse ox, so they don't have to take the whole monitor, but they'll just put like one of those finger probes on and use that. So when you get to recovery, lots of places have kind of a template for how they assess things. But ultimately, what they need to do is kind of cover all these bases. So what usually happens to kind of streamline things, you'll get them to recovery and then they start getting hooked up to all the monitors. And lots of places, they will wait to have any sort of sign over or handoff until the patient's being monitored from that standpoint. Some places it's formal, some places it's informal. And then who actually hooks the patient up varies from one place to another as well. Um, Personally, I feel like it's my patient. I'm responsible for things. So I don't expect the PACU nurse to do everything for me. So usually I'll start hooking stuff up, they start hooking stuff up, and we get things accomplished. Lots of times the OR nurses will help out with that as well. So just kind of figure out the flow for places. While you're doing that, you can continue to assess the patient without any problems. One of the biggest things we really worry about after anesthesia is hypoxemia. So big things that kind of come into play there: older patients, people that are sedated, which if this was general anesthetic, everybody's sedated, or at least has some sedation still in circulation. Do we have them on oxygen? Do they need oxygen? Is the oxygen adequate? Some places they put everybody on a nasal cannula. Some places everybody goes on a face mask and then they wean them down to a nasal cannula. Some places they just wait and see what happens. So just be mindful of what the practice is there. Like I said, we try and get those patients connected to the monitor as soon as possible. From your standpoint, it's kind of nice because you can start identifying any abnormalities. You will see that in spite of your best efforts to monitor the patient and care for them, that things will change between point A and point B. So your patient that was 100% in the room may now suddenly be 50, 60%, even though they're still breathing. Maybe they're not breathing as adequately as you are. Seeing fogging in a face mask is nice, but it doesn't really tell you how much volume they're pulling or anything like that. So you can see that lots of things change in that time period. Having those monitors on quickly is pretty valuable. So when you get there, you're going to reassess your patient, get them on the monitors, and then after that, you're going to give a report to the PACU RN. They're going to go ahead and assess the patient, and then they kind of transition into a couple different phases of recovery. So something for you to think about when you start giving a report. Some places have a detailed format. Some places you will call a report from the OR to PACU, so when you get there, you don't give a report. Sometimes the operating room nurse gives a report, and then you do. It really just varies depending on the facility. Um, at my current facility, the OR nurse gives a report about the surgical side of things, and then I give a report about the anesthetic side of things. Other places, the OR nurse finishes pushing the bed and they're gone. So you may have to talk about what happened during the surgery as well. Just be mindful of that. Other things for you to think about when you're doing this: what's important to say and what's not important to say. I'm sure we've all given a report or gotten a report on a patient, and you're about 20 or 30 seconds in, and they're still talking, and you've stopped listening. Same thing happens in the PACU. You guys will see when you first start off that it's very hard to kind of understand what's important to say and what's not important to say. Again, it really depends on the facility. Some places give very detailed reports. Other places, it's really tied into what's important and what's not important. Things I usually think about: the type of anesthetic they had, kind of important features, any significant past medical history, like diabetes is usually a big one, or blood pressure issues, stuff like that. If you tell the PACU nurse every medication the patient got, every dosage the patient got, they have stopped listening long before you get to anything important. So just be mindful of that. On the other hand, they may ask you strange questions, so make sure you're kind of tuned up on your patient. So no matter what you do as far as report, try and make it organized. Some people, especially when they're first starting off, will write it down. But if you just hop around, it's very hard for people to kind of follow your train of thoughts. Other things to think about: make sure they're listening. We all run into people with ADD that only listen for about 5 or 10 seconds. So if they stop paying attention, start doing something else, sometimes I'll just stop talking and wait. Sometimes I stare at them. Sometimes I'll ask, are they listening? Especially if I'm going to give something kind of important. But it's kind of a tenuous thing. You don't want to offend them, but at the same time, you want to make sure that you're giving them important information and they receive it. So this is kind of a common handoff that's used. I'm sure you guys used SBAR before, but this really goes into great detail about things. Very good information. The problem is there may be too much information here. So this really covers a lot of the pertinent areas for problems. So just like you did an anesthesia timeout, there's a timeout here for PACU. So make sure it's the correct patient. It seems silly, but sometimes they will be getting two different J. Johnsons. So make sure you've gone to the right PACU slot. It may be a matter of checking the patient's name, bracelet, obviously go over the surgeon and the procedure, any pertinent allergies, medical history. A lot of times they can glean this information from the EMR, so they don't need to ask you. But maybe it's something that's very pertinent to PACU, like the patient's allergic to morphine or fentanyl. So you want to make sure you highlight that so they don't try to give them that medication. Um, so just kind of some basic stuff to think about here. And then ultimately, like, what are you going to do with the patient? Are they going home? Are they going to the floor? Are they going back where they came from? And then any issues do you anticipate? They were nauseated beforehand. This is what we did. But if they get nauseated again, here you go. And you've already put in orders that cover those things, but I like to reiterate it if it's really important. And then at the end, make sure that they don't have any questions. This kind of drops it down into a little bit easier version of all those things. Again, you've got handoff information about the patient, allergies, history, those sorts of things. Doesn't go into quite the same depth as the other one, but still covers a lot of the same information. So it doesn't really matter which format you follow. Just make sure you have something and stick with it. And it may, like I said, vary greatly from one place to another. This is a very detailed form. Um, Again, just pick something that works for you, and then it's probably going to change from day to day to day. And as you get a little bit further into your clinicals, you'll figure out what's important, what's not important, at what point they stop listening. Early on, you're just going to talk and talk and talk. This doesn't just happen when we go to the PACU. I know this is a PACU lecture, but sometimes we take our patients directly to the ICU, and it's important for us to have kind of that same handoff there. This is a form we use when we go to the ICU. And same reason, except it's a little bit more complicated. Kind of the workflow for patients going to the ICU that weren't there to start off is usually the surgeon calls whoever the hospitalist, intensivist, admitting doc is, and they agree to take them to the ICU. They'll give them some information, but they may have missed a lot of key stuff. Kind of report for them would be they're coming to you for postoperative respiratory failure. They don't tell them why they have respiratory failure. They're going to leave out the fact that it's because they had to get 20 units of blood or any of those sorts of things. So this gives you a chance to kind of get everybody on the same page. The one thing you'll see that's a little bit different here is usually you have the surgeon involved in this as well. So whether it's the surgical resident, PA, NP, or the staff surgeon themselves, somebody goes up there so they can answer a lot of those questions. Now, the one thing you may see is this may be somebody that's basically being admitted to their service. So maybe you have a trauma patient and the patient's going to the trauma ICU. So whoever the surgery resident is may be handing off to a colleague as opposed to another service. But make sure you've got that handoff as well so they kind of know what's going on. And when we get up there, things we want to think about, obviously somebody on the physician or house staff side receiving the patient, whether it's the ICU NP, PA, surgery resident, whatever you have. And then on the nursing side, you'll usually have the patient's nurse, and a lot of times, like the ICU team lead will be there as well. That way, they kind of all know what's going on, and it's a nice time to kind of clarify things. Now, mind you, that you've already called report to the nurse that's getting this patient, so this is just an opportunity for a little bit more detail. And it varies from one patient to another, kind of how in depth you have to go. So I told you earlier there are two phases of recovery. You have phase one and phase two. So phase one is your immediate postoperative phase. It's a lot more intensive. They do all the continuous hemodynamic monitoring the same as you would in the ICU. And usually they monitor the patient and document vital signs every 5 minutes. Most of the time, the PACU nurse is going to stay at the patient's bedside for at least the first 15 to 30 minutes before they wander off. And if they do, they're not going to go very far. Most places, they will not care for another patient during this time period. It's kind of a one-to-one time. Now, there may be somebody that's floating around to help them with this. It just kind of varies from place to place. So anybody that's been under general anesthesia has to go to phase one. The reason I say that is sometimes we'll do like maybe a cataract or glaucoma or something like that, and they just get a little bit of sedation. We still want to monitor those patients, but they don't need quite the same intensive monitoring. So those patients may do what we call bypass phase one. So they skip this stage and just go straight to phase two. Phase two is really when they're getting ready to go home. So they don't need quite the same intensive monitoring, certainly not the vital signs every 5 to 15 minutes. And the same kind of parameters, you want to keep their vital signs within 20% of baseline. The one thing that's a little bit different from our perspective is they're no longer under an anesthetic. So usually you see their vital signs start to get back to where they were. With that in mind, if you have a patient that you've had to run on a vasoactive infusion, a lot of times the PACU is not going to take that medication. So you may have to figure out how you can wean that off before you take them to recovery. Phase two is really where they go and get ready for discharge. So there's a bunch of different scoring systems out there that they use to evaluate them. The Aldrete score is probably the most common one, but there's some other scores as well. And this is basically just making sure that patient is back to baseline and they're safe to go home. So this is that Aldrete score. This is the standard version, and it's pretty straightforward. It's almost like an APGAR for PACU. So activity, they're moving everything voluntarily. They're breathing, they're coughing, their blood pressure is back to normal. They're awake, they're well saturated. So you kind of think about all the body systems here and they're back to normal. This is a modified version that just goes into a little bit more detail about things. The O2 saturation is a little bit lower. This is really used more for like sedation monitoring sometimes than necessarily discharge criteria. And what I mean by sedation monitoring is not something like a RASS score, but as far as like sedation while they're there. So a little bit more detail for you there. You'll have to know what the facility uses just so you're familiar with it, but it's not like you're having to calculate these scores for, PACU presentation. You probably need to know these scores for the exam. This is the post-anesthesia discharge scoring system. You'll notice there's a lot of overlap between here and the Aldrete, but it takes a couple other things into account, like nausea and vomiting. If you have somebody that continues to have nausea and vomiting, they don't need to be discharged home like that. We will admit patients to the hospital because they have continual nausea and vomiting. Other things, we don't send people home with continual pain. So if your patient's hurting, you may need to address it. You may need to bring them into the hospital if you're not able to get it under control. And then from a procedural standpoint, look at their wounds. If you've got somebody that's oozy or continuing to bleed, they're soaking dressings, they don't need to go home like that. We need to figure out why that's happening. So I like this score a little bit more. It's not quite as technical. You're not looking for specific numbers for the most part, and it takes the whole patient into account. Are they bleeding? Are they nauseated? So, in my opinion, this is a little bit more of an appropriate scoring system. So phase two, they take vital signs every 30 to 60 minutes. The general standard is that you have to stay in each phase for at least 30 minutes. But like I said, if you bypass phase one, you may just stay in phase two for 30 minutes. But a lot of times they're going to wind up being there an hour. It also depends on the patient. Some places will take kind of heavy sedations to phase two. Sometimes they have to be fully awake when they get there. So be mindful of what the process is. Technically, if they haven't had a general anesthetic, they can go to phase two, but there's lots of times we do sedations that are basically general anesthetics without an airway. Otherwise, kind of the same thing from a monitoring standpoint. Airway's got to be intact. Pain and hemodynamics need to be kind of squared away. Now we're going to talk a little bit about some of the complications we run into. Some of these we've talked about in other lectures. Some of them are a little bit new, but this is kind of an overall complication rate that we see. The good news is out of almost 20,000 patients, only about a quarter of them had complications. And when we talk about complications, it may not be something huge. We know that there's a significant number of patients that have nausea and vomiting. So if this was 25% of the patients had complications, about half of those had nausea and vomiting. It's also a little bit older study, so they didn't necessarily have the best interventions done for postoperative nausea and vomiting. So keep that in mind when you think about your patients. What can you do to prevent these common complications? So you've got nausea and vomiting. Upper airway support is a complication, but it's not necessarily a complication. So it may be the patient came out with an oral airway. That may have been the intended kind of flow. I intended to extubate this patient deep and put a oral airway in or a nasal airway or something like that. So it's not necessarily a problem, but when you go some places, they take things to a little bit of an extreme. You'll notice there's quite a bit of variation, like I said, from one PACU to another. So if you've got some PACUs that are extubating patients, and you have other PACUs that everybody has to be wide awake and ready to be discharged when they get there. So be familiar with kind of the flow and the accepted standards in your PACU because they do vary quite a bit. If you bring out somebody extubated deep in an oral airway and all they're used to is patients that were ready to go home, they're going to get upset. On the other hand, you kind of have to think about who winds up working in the PACU. Usually you kind of have two flow processes there. You'll have ICU nurses that started getting burned out and wanted something with a little bit better lifestyle. So they got kind of the Monday through Friday PACU job. They're usually pretty squared away. On the other hand, you may get those same people, but never went to the ICU, and they were just excited about that lifestyle. So they may be lacking some of those critical thinking and critical skills. Just be aware because they're not all the same. Hypotension happens not a whole lot, but it is a problem in PACU. And usually what you see is that people are hypotensive when they first get there. So the volatile gases are still wearing off. Maybe they were a little volume depleted. Maybe this is somebody that you were having to bump with some sort of vasopressor agent in the OR, and now their blood pressure is a little soft. So when you have those patients and you get them over to PACU, don't walk away from somebody that's having not only that, but any of these problems. You're the best one to deal with those situations. So if there's a problem, don't walk off. Stay there and get that patient stabilized until you can either fix it or hand it off to somebody else. So if some CRNA is the one that's running the PACU that day, give them a call. Say, hey, this is what's going on. This is what I've done. Get them to come over there and see that patient. Because you don't want to be known as the one that drops off problem patients in PACU, and you certainly don't want to have a bad outcome that you walked away from. Dysrhythmias happen as well. And when I say dysrhythmias, I don't mean like these people are all going into VFib or VTAC. It may be bradycardia, it may be tachycardia. I had a patient the other day that went into WPW, and it wasn't really my patient. It was a guy that had an ortho procedure. I went over and blocked him, stood there. I usually stand there for about 5-15 minutes charting, talking, those sorts of things. I walked off to go block somebody else. And the PACU nurse calls me and says, "Hey, your patient's in LAST. LAST is local anesthetic systemic toxicity." And I said, "Okay, I'm coming. What's going on?" And she says, "Well, his heart rate's 150." I'm like, huh. I mean, that could be LAST. It does cause some dysrhythmias, but it's not real common. So get over there. The doc that was covering PACU got there about the same time I did. Fortunately, he was also the one that was covering that room. Well, neither one of us knew, and the patient hadn't disclosed until we started talking to him that he had a history of WPW in the past. So I'm assessing the patient for LAST. He's trying to dig through the medical record to figure out what's up. And no signs or symptoms of LAST otherwise. No tingling, no ringing in the ears, no really arrhythmias other than that tachycardia. And then we noticed he had a little bit of a delta wave there, and kind of one thing led to another as we got the 12 lead. And we figured out that he'd had this, and he just never went to his cardiologist for like the last 10 or 15 years. He'd only had 2 episodes in that time, and they both broke spontaneously. Wound up giving him a little Esmolol. But you'll see things like that happen. It may be PVCs, it may be PACs. We see some arrhythmias related to temperature changes, whether it's your patient is febrile and tachycardic, or maybe they're cold and they're bradycardic. Hypertension happens as well. Usually it's not unknown hypertension. These are commonly patients with a history of hypertension that maybe miss their morning medication, maybe because we told them not to take it, any number of things. The other thing you'll see that we kind of forget about that can cause hypertension is pain. Pain causes hypertension. But another one we forget about a lot of times until we've tried to really maybe too much address that pain is urinary retention. So lots of times, like we talked about the other day, patients will have a Foley or they'll have an in and out catheter, and then it comes out before they get to recovery. When you have somebody that really needs to pee and they can't, their blood pressure goes up. So we start off thinking about other things. Maybe the patient can't explain it. Maybe the patient's confused, or they don't know why their whole body hurts. But so we start treating that pain pathway, and then we figure out that they really just need to pee. And now you've got the other problem, they're hypotensive. So just kind of keep that in the back of your head as far as the differential. You may experience patients with altered mental status. Maybe it's just prolonged sedation. So be mindful of the medications you're giving them. Some things like gabapentin and dexmedetomidine have been implicated in prolonged sedation. So just be mindful of that. Patients to potentially ruling out MI doesn't happen very often. And usually if it does, it's happened in the operating room, and then we're just getting them to recovery for assessment. But it can happen there too. Sometimes they, get through whatever they were going on with in the operating room, and now they start having ST changes. And then you can also have cardiac arrest in the operating room, or excuse me, in the recovery room. Usually, if that happens, it's due to one of two things: either respiratory arrest due to an occluded airway, or that intraoperative MI. So just kind of keep those things in the back of your mind as you're working through different differentials and kind of problem areas. Alex asked about, do we need to know both the PACU discharge score and the Aldrete score? Yes, I don't worry so much about the modified because it's not that different, but just know one of the Aldrete scores and then the PACU discharge scoring system. All right, airway complications. As I've kind of hit a couple times, this is really one of our biggest problem areas. So the big thing we have to worry about here is generally airway obstruction. A lot of times we cause this problem for ourselves because the patient's either too sedated, has tissue edema, maybe they were difficult airway, maybe they progressed to laryngospasm, maybe the surgeon causes it. This is somebody that's had airway edema, and now they've got an expanding hematoma in their neck, any number of things. Maybe it was a traumatic intubation and they've got vocal cord palsy. Maybe this was something like a thyroid or a parathyroid, or they were digging around in the neck for some reason, and they've caused damage to the recurrent laryngeal nerve, and now they've got vocal cord palsy. The bottom two are ones that we really see more and more that are kind of sad because they're things that we can kind of treat. Um, Residual neuromuscular block, just make sure your patients are fully reversed. When Cigamidix came onto the scene, we figured out we kind of had a very safe medication that we could use for everybody. But as we've done that, we may not necessarily give the most appropriate doses. So calculate the patient's actual dose based off their train of four and make sure that they're getting an appropriate dose. Also, and at some point in your careers, you're going to see this. When you have somebody with residual neuromuscular block, it's scary for them. It's going to be kind of scary for you and the Pacu people because they kind of look like a fish out of water. They'll be flopping around on the bed. They're not breathing well. They're moving everything, but they just don't have strength. So maybe you ask them to pick up their arm and they can pick it up, but they can't hold it up. It just kind of flails up there and it's down for a second. The good news is, like I said, it's pretty highly treatable. We can usually give these people a second dose of something like Cigamidix and they improve. Um, OSA, I say, is highly treatable, and I don't mean that like we can resolve their condition, but we can either prevent them from having problems or treat them. The big thing we think about is not having somebody that's overly sedated where they've lost some of those pharyngeal reflexes. So that's something to think about, but a lot of times what we'll see is these patients need to go on CPAP or BiPAP. It's generally not a surprise to us. And I say that for a couple of reasons. One, it may be a matter of us recognizing it in pre-op because they told us so, or we look at their body habitus, or when we give them propofol on induction and they obstruct, it's kind of a clue that they're probably going to do the same thing on the back end. So, kind of risk factors for us to think about for airway complications. On the patient side, if they have breathing problems before anesthesia, it's not magically going to get better. So, any sort of breathing problems, body habitus, cardiac issues, all of those things will contribute to potential airway complications. On the procedure side, think about what could cause it. So, if you're working anywhere around the chest or diaphragm, it can be problematic for us, either because it hurts to breathe, they wind up with some muscle weakness. Any sort of neck or ENT pain procedures can cause problems for you. So, think about swelling, think about nerves being severed, stuff like that. Long procedures are problematic, especially long procedures in weird positions. So just be cautious with that. And then on our side of things, obviously, if it's somebody we're worried about airway complications, them maintaining their own airway throughout the case is better than a general anesthetic, but that's not always possible. If you give somebody something like a muscle relaxer, make sure that it's fully reversed. Other things to think about: did you use the muscle relaxer because you needed to put the tube in or because they needed to have it for the case? Be cautious with your administration of opioids and other sedating medications in patients you're worried about their airway. I would much rather have someone awake in pain and breathing than sedated and having to go to the ICU intubated because I gave them too many opioids. So, talking about that upper airway obstruction, really the biggest causes we see are loss of pharyngeal tone. And generally, we tend to cause this problem. It's usually because the patient is over sedated. Maybe they were on a volatile anesthetic and it's not out of their system yet. Maybe they were getting a like a Tiva and a propofol infusion and it hasn't redistributed. But this is usually on us. There are things we can do to treat it, but basic things are really all you need to fix this. Very rarely will it progress to the point of having to reintubate a patient or give them succinylcholine. So little things, just take one finger and lift up on their chin. If you sleep with somebody that snores like a bulldog, then guess what? You can wake them up in the middle of the night by opening that airway. The downside is that you're going to have to keep holding it. Other things you can think about: positioning. So the reason this happens a lot of time is that that tongue relaxes back into the airway. So if you take somebody's head and turn it to the side, instead of that tongue falling straight back into the airway, a lot of times it'll fall off to one side or the other. So you may not have to hold that airway open anymore. You can just turn their head. If that doesn't work, you can always put an oral or a nasal airway in there. Sometimes if I have somebody that I think is high risk for airway obstruction, maybe this patient's huge body habitus, I'll go ahead and put those nasal airways in beforehand before I even wake them up. The nasal airways tend to be tolerated a little bit better, and I'll take it a step further. I'll go ahead and put lidocaine on there. So usually for the time period they're in their nose, they're not bothered by it. Oral airways work a little bit better, but they're far more stimulating. So as soon as they start waking up, they're going to want to pull that out. And you'll see when patients wake up from anesthesia, it's not like a very linear process. They kind of wake up and go back to sleep, wake up and go back to sleep. So they wake up, pull that oral airway out, and then they go back to sleep, and I'm back where I started. So that's why a lot of times I'll do the nasal airway since it's better tolerated. Laryngospasms happen. All of us have had a laryngospasm before. We're usually able to break our own, though. Think about this when something goes down the wrong pipe. So, for some reason, the vocal cords close and they're not letting any air in or out. Things we worry about then, if it's sustained, negative pressure pulmonary edema can happen. Usually, this isn't a sustained process, though. This is something normal in our body to prevent us from aspirating whatever it was that was trying to go down there. So, what causes this? Again, this is probably going to be on us. It's usually a combination of two things: one, the patient being sedated, and two, some sort of foreign substance being around the airway. So, problem areas, maybe it was traumatic intubation, they've got a little bit of blood in there. Maybe they had some secretions back there that we didn't adequately suction out. You can also do everything right and still have somebody laryngospasm. It's kind of like esophageal intubations. It's going to happen. The important thing is just that you recognize it happens. One of the things that drives me crazy when I watch other providers is when they take monitors off. So you'll notice there's a whole lot of people that will move a patient from the OR table to the stretcher. And before they do that, they take off all their monitors. They may have extubated the patient already, they may not. Trying to get those monitors back on while somebody's laryngospasming and you're trying to treat it or something bad happens is very difficult. It's really easy to move your patient 3 feet to the left or the right and keep those monitors in place. And that way you recognize things like your patient's desaturating. You also have to be very vigilant and watch their airflow. So maybe your patient was doing fine before you moved them over, but for some reason, whatever moving process, setting them up, a little bit of something shift around in their throat, and then they spasm. If you're not paying attention to them, especially before you roll out of that room, it's going to be 2 or 3 minutes from the time you leave that room till you get to Pacu and they get back on monitors. So imagine somebody has laryngospasm before you left that room, you didn't notice, and they don't breathe the whole time over there. Not a good situation. So even if you're not using actual monitors during transport, make sure you're looking at that patient. Look at that face mask. See that there's fogging in it. This is just a little touch on negative pressure pulmonary edema. Fortunately, I've never had a case of this, but I can think of lots of patients that I've seen, especially that came from other facilities, that had negative pressure pulmonary edema. And basically, what happens is that for some reason the patient got light, or they were breathing spontaneously and the tube became occluded. So with pediatric patients, because that tube's a lot more kind of fragile or floppy, not as dense, sometimes just that circuit hanging on that tube will be enough that it flops off to the side and occludes it. So if you have somebody who's breathing spontaneously and that tube gets occluded, now you have that diaphragm pulling a vacuum against the lung. And then when it does that, it's going to pull that interstitial fluid out of the lung or out of the tissue into the lung. Can be pretty devastating for these patients. Like I said, I've seen multiple patients wind up on ECMO and several die after this. So it can happen because of that, but by far the most common etiology for this is going to be laryngospasm that's untreated. So think about that patient that's having a laryngospasm for that 2 or 3 minutes till they get to Pacu. Well, now they've desatted, now they've got all this fluid in there. Really difficult to manage. So vigilance is important, and then addressing it very quickly. So one of the easiest treatments, if you have a tube in place and your patient, for some reason, starts developing this, and kind of the situation you'll see happen there, you have somebody, maybe you're waking them up, maybe you're putting them to sleep, maybe they're starting the surgical procedure and they weren't as deep as you thought they are, but for whatever reason, they bite down on that tube. And this can happen with LMAs as well as endotracheal tubes. But when they bite down on that tube, it occludes it. So now they're trying to fight to breathe through a tube that they're holding closed. Seems crazy. You're like, hey, just let go. But it doesn't work that way a lot of times. The easiest treatment for us at that point is to deflate the cuff, because now they can breathe around that tube. But you have to recognize that's happening. So just be cautious with that. It doesn't happen very often. Most of us do a pretty good job of getting our patients deep enough and being very vigilant, but it can certainly be pretty devastating if it does. So things you're going to see when somebody laryngospasms is it starts off with kind of a faint inspiratory stridor. If you hear that at all, it's kind of easier to figure out what's going on. But a lot of times it kind of presents with the patient starts to desat. And the problem is we look at the patient and we have this bad habit of looking at their belly or looking at their chest and see that it's moving and assume they're breathing. They may not actually be breathing. They're obviously trying to breathe, but there may not be any actual air movement. So don't rely on the patient's chest or abdomen moving as being a sign of respiration. Actually feel or see air movement. Whether you're holding your hand over their mouth and you can feel it, or you look at that mask and you see that there's fogging, any of those sorts of things, because the movement of the chest or abdomen is not necessarily reassuring. So, how do we treat it? If you're not able to break it at first, go ahead and get help coming to you. Like I said, a lot of times we can just use our hands and hold the airway open. We may need to do a jaw thrust, but usually the go to after that is going to be positive pressure. So, you're going to take the APL, close it somewhere between 40 and 70, get a good seal on the patient's face, and that positive pressure is going to force that glottic opening, that glottic aperture open. And when you do that, the patient's going to cough. And if you're coughing, that glottis is open. Now, the other thing you have to be mindful is if they're coughing, there may be secretions there that are coughing back onto that glottic opening. So be cautious with it. But if you see them coughing, it's a reassuring sign. A lot of people, when they extubate their patients, will extubate them to positive pressure. So some people will close the APL to like 20 or 30 when they pull that tube, and then they put it right back on that patient's face with the face mask. So that way they've got some positive pressure to kind of hold those cords open. There's a variety of different techniques out there. Some people do that. Some people will extubate to suction. I don't know that one is necessarily better than the other. Just figure out what works for you. Then go through and make sure you suction the airway pretty good to remove whatever the offending substance was. You may need to support their airway with like a jaw thrust or an oral or nasal airway at that point. Other things you can do, there's something called Larson's point or the laryngospasm notch. You can apply pressure there. And it's really back here, kind of in between the mastoid process and the base of the skull. And I want you to use this, but be cautious with it. Talked to a resident the other day, and it wasn't her case, but they thought she'd been involved in it. And the patient actually wound up with a bilateral dislocation of their jaw from somebody doing this. It was a bad laryngospasm. It needed to happen, but it wasn't recognized that the patient had dislocated their jaw. So just be mindful. Very few things we do are totally innocent. There's some complications associated with this. So I kind of described it for you. Usually, as soon as you do this and you hold pressure, it's going to resolve. The way I will do it is I close my APL to 70, put the face mask on there, and then I take my thumbs and slide them back behind the mandible and kind of use that to apply that pressure. So you're basically just going to kind of slide your fingers up there in between the ear and the mandible and push forward. And a lot of times, the combination of those two things will be enough to break the laryngospasm. There are a few times that it doesn't break, but it's pretty rare. So if you do have somebody that it doesn't break, usually you're going to see that they start to desat. Their heart rate goes up, your heart rate goes up, but you've kind of got to work through things quickly at this point, or they're going to check out on you. So generally, kind of the process you'll see if it's an adult, they become tachycardic and then they trend to bradycardia. If it's a kid, they may go straight to bradycardia. You may not see the desaturation until after their heart rate's down in the 20s and 30s. So how do we treat it? And there's three things that we use: atropine for the heart rate, but be mindful what they really need as far as their heart rate is oxygen. So we don't use the atropine as often as we used to, but it's something to consider. We put propofol here because you'll figure out that a lot of times deep sedation or just a bolus of propofol is enough to break that spasm. And usually we have a little extra propofol sitting there. So you may be able to give them 20, 30, 50 of prop, and it's enough to break that laryngospasm. It doesn't always work out that way, but because it's something you can do quickly, it works out most of the time. If I had probe sitting there and I had sucks sitting there, sucks would also be obviously be my go-to, but I may not have it quite as quickly available. Other things you can do: deepen your anesthetic. So I may, while I'm holding that Larson's maneuver, holding pressure with my face mask, I may just turn my SIVO or ISO up as far as it'll go and see if deepening them is enough to make them relax as well. And then ultimately succinylcholine. So the dose of succinylcholine varies a little bit, and you'll see that depending on your source, that there's not a real consistent dosing. But usually what we found is that a dose as small as like 0.1 milligrams per kilogram is enough to cause that spasm to break. I've probably given sucks 4 or 5 times in my career. Most of that was when I was in residency, and you guys are going to encounter this too. There are people that it seems like create situations or cause laryngospasms. Some of them are like, they act like they're doing you a favor so you can work through it. I think they're probably just sloppy anesthetist. But I've only had one pediatric patient laryngospasm on me that I had to give sucks since then. And that kid wound up actually having to go to the PICU intubated. And we did all the normal things, but it's not very common. After you do that, because you give such a low dose of sucks, you may not have to reintubate them. You may be able to ventilate them effectively, or you may have to put a tube in and then, get them to the ICU or get them to Pacu on a wake-up bed. Sometimes you did everything right the first time and they still spasm, so just be mindful of that. Airway edema or hematoma is not necessarily a common complication, but can certainly happen. Usually when we see it happen, it's people that were intubated for a long time or they were in a weird position like Steve Trendelenburg or prone. You'll see that patients that have large fluid shifts like big blood losses and then they get aggressive fluid resuscitation are at a higher risk of that. Things for us to kind of figure out that the airway is potentially edematous. When you look at their eyes, you look at their face, and you see that it's puffy and it wasn't like that, it probably didn't just stop there. These patients probably have some edema in their airway. So what are we going to do to kind of evaluate things? You can go in with a fiber optic scope and look around the cuff, but usually what we do is just a leak test. So we're going to make sure that we've suctioned them to be dry, and then we're going to drop that cuff down. And when we do that, we want to make sure that we're able to hear air moving around the cuff. Sometimes you can just hear that with your ears. Sometimes you have to put your stethoscope around their mouth to be able to see or hear it. The other thing you can do is look at your ventilator, and when you see that your exhaled tidal volume has got a pretty big disparity from your delivered tidal volume, you know that air is leaking out around the cuff. But with that being said, if I only have 100 mLs of air leak, I'm probably going to be a little bit cautious about pulling that tube out. So airway hematomas happen. Generally, these are going to be related to the surgical procedure. We can dissect next with an endotracheal tube, but it's generally not a good idea. Most common time I've seen this has been in post-thyroid patients. It may happen in the PACU. I had a patient, I think it was like 3 years ago, actually went home, and the family wasn't able to describe exactly what happened because it was in the middle of the night. But apparently she woke up, started coughing, and somewhere in that coughing process popped a clot in her neck, came back to the ER with her neck huge, wound up getting a surgical airway there. So the ones I've seen have been thyroids. It's also possible with carotid surgeries. I think the vascular surgeons are generally a little more cautious than the general surgeons. When you see people that have thyroidectomies, a lot of times for vascular control, they use clips, and those clips may not work quite as well as possible. So just be mindful of that. So how do we recognize that's what's going on? So big ones, patients having difficulty breathing. Don't kind of skip over physical assessment. A lot of times these patients have like blankets on them. We talk to them. They sound a little hoarse. Look at that neck. You may be able to see that there's a big bruise or hematoma there, and it started to swell and swell and swell and is putting pressure on the glottic opening or above the glottic opening. It may be large enough that the trachea has kind of been shoved over to the side. Obviously, that's pretty significant. Keep in mind, if that's happening, it may be a pneumothorax too. A lot of times these cases are in close proximity to the lungs. But if that neck is swollen, especially if it's kind of visibly bruised, it's probably going to be an expanding hematoma. But the reason I mentioned pneumothorax, if you have somebody with a pneumothorax, you may notice that they have subcutaneous emphysema there as well. So that may cause swelling in the neck. So how do we treat it? The easiest way is to decompress the airway by releasing the crypts or sutures or whatever's on the incision and then removing the clot. Most of us are not comfortable doing this, but it may be the only option for the patient. So a lot of times what we do is consider intubating the patient while we're waiting on the surgeon. But if you have an airway that's already being compressed by hematoma and you take away muscle tone with a muscle relaxant, it's going to be even harder to get them intubated. And now you've made the patient apneic. So if it were me and I didn't feel comfortable releasing the clips, I would probably consider an awake intubation. The other thing you have to think about, whatever is behind this is bleeding. So what did we just talk about caused it? It could be a carotid surgery. So if I've got a clip that pops off the carotid, now I just opened up their neck. Now their carotid is spurting blood everywhere. I'm probably not going to be real effective at controlling bleeding from somebody's carotid. So you kind of have to weigh the situation and figure out what's going on. In a perfect world, you catch this very early on before it causes problems and you get that surgeon back there. But that may not be the case. So just be mindful that you may be the one in the situation that's having to cut those sutures to relieve that pressure. Vocal cord palsy happens. It's kind of the same situations. A lot of times you'll see this with thyroids, parathyroids. Sometimes patients will have like laryngeal or tracheal biopsies done. Um, Overinflated ET tubes can also cause it, so that's on us. But usually it's going to be kind of external neck surgery that winds up severing one of the laryngeal nerves. Most of the time, if it happens, it's going to be unilateral, which is not good, but it's better for the patient than having bilateral nerve injury. And what you may see if they have just unilateral paralysis is they may be talking funny. It just depends on the patient. They kind of sound kind of husky, like you do first thing in the morning when you wake up. You may notice that they're coughing a little bit. Their voice sounds different, which, we're not around these people often enough to recognize that. But maybe the family member comes in and they say, hey, he's talking funny. You may be able to see this before the end of the case. I have a couple surgeons that will have us go in and look at the cords on extubation. So there's documentation that they're able to tense up. Not the greatest situation for the patient because I'm in the process of waking them up. They want to see their vocal cords breathe and move, but they also want them calm enough that I can stick a scope in their mouth. So you'll run into kind of weird situations like that. And this is just an example, couple examples of that. Sometimes it's hard to see. That's why we prefer to have the patient either talking or moving. Now you can go in post-procedure, just numb up their nose, go in with a fiber optic scope and watch their vocal cords, and that way you can have them talk. ENT is pretty good at this. A lot of times they'll do like nasal and airway exams on patients awake with just topicalization. We're probably not as good at it as they are because they do it all the time and we don't. But it's certainly something that can be done. You can have bilateral recurrent laryngeal nerve injury. If this happens, both cords are paralyzed and it's kind of stuck halfway open and halfway closed. Because there's no muscle tone, though, you may see that those cords will actually close. And when that happens, you're going to wind up with airway obstruction. So now they can't breathe. Not very common, but it certainly can happen. So just be very cautious and patient. And if you have somebody post-procedure that they can't talk, and they will look like they're trying to talk to you, like they're kind of like in that stuck breathing out position, have a high index of suspicion, especially if they have like neck surgery or something like that, that they may have bilateral injury. And this is just an example of both those cords being paralyzed. You'll notice that right cord is also kind of edematous. That's not always common, but it was in this situation. So you'll notice that thyroid surgery has been implicated in a lot of these different problems, and it's because they're very close to those nerves. So one of the things we do a lot of times is use a tube that allows us to monitor the laryngeal nerves during that surgery. It's called a NIM tube. Other things you see with thyroid surgery, hypocalcemia. You can see this 24 to 48 hours post-op. It can also happen a little bit faster than that. You may see it with thyroid surgery. You may see it with parathyroid surgery. So just be mindful of that. Two different signs you're going to see mentioned on exams and on boards. Chostek sign, which is facial spasm, and then Trousseau sign, which is a carpal spasm. So it can happen for a couple different reasons. Usually it's because of some sort of laryngeal nerve damage there that's caused hematoma, let me back that up because that's going to get confusing. So you got three different things that go on with thyroid surgery. You can have hypocalcemia. You can also have the hematoma formation, and then you can also have the recurrent laryngeal nerve damage. All three of those things may be fairly quick, or you may see that they take a little bit longer to develop. Other things you see as far as respiratory stuff, this is a big one, and I kind of talked about it earlier. But in the past, we had to be pretty cautious with how we administered our neuromuscular blocking agents. Because when you're reversing somebody with neostigmine and glycopyrrolate, you really have to have something to work with. On the other hand, if you're giving somebody Sugamidex, I can take somebody that I just gave that big 1.2 mg per kg dose of rock and give them enough Sugamidex to overcome that. So we got a little cavalier with our muscle relaxants after that. In the past, we would have given like 1 dose, 2 doses, and then we'd make sure it was wearing off by the end of the case. When we started using Sugamidex, we may have stopped doing that, and we kept people relaxed a little bit longer. So as a result of that, we started to see the patients were tending to be a little bit weaker in PACU. The other thing you'll see is that some of our medications contribute to this. So patients that receive like magnesium infusions or boluses, or patients that maybe were on a lidocaine drip, both of those will contribute to residual muscular paralysis in PACU. So how do you assess the patient? Like I said, if you see them, it's going to be the first thing that comes to mind the next time you see somebody like that, because they really do look like a fish out of water. They're trying to move everything, but it's just kind of weak and floppy. Do basic things if you can. Get them to hold your hand. Get them to stick their tongue out. Get them to do some sort of like muscular exertion against you. So, squeeze your hand, hold your hands up, hold their head up. When we talk about extubation criteria, that's why one of the things we look for is somebody that can hold their head up for 5 seconds. The other thing you'll see, they may have all of these things, but they may still have some airway reflexes that are lacking. So if I have somebody that just seems like they're not breathing well and they got a neuromuscular blocker, one of kind of my rule out things is I'll go ahead and give them some Sugamidex just to be on the safe side. We talked about sleep apnea before. Just be mindful of that. Usually these are not surprise patients. Other things to think about when you design your anesthetic plan for these patients, make sure that they're fully awake at the back end. This is not somebody you want to extubate deep. They need to be able to control their own airway. Consider things that will go away quickly. So when you're thinking about opioids, maybe I don't want to give them a long-lasting agent. I may do something like remifentanil and then use something like ketamine to control their pain. You may consider a regional anesthetic technique for these patients. Other things to consider, talk to these patients in their pre-op visit and ask them to bring their CPAP. If not, you may want to call respiratory before you even wake the patient up and have them bring CPAP to recovery so they're there waiting on you. The stop bang score is kind of how we evaluate sleep apnea. So I kind of gave you the down and dirty version before. We've all seen people with sleep apnea and we recognize it, but this is really a way for you to quantify it. So the stop part of it is, do you snore loudly? Now, they may not know they snore, but somebody else tells you they do. You will interview patients and they're like, no, I don't snore. And then you talk to the person that sleeps beside them and they're like, yes, you do. You keep me up all the time. Or if I don't go to bed first, I can't get to sleep because you're snoring. During the day, do they feel tired, fatigued, or sleepy? And I'm not talking about you guys that are exhausted from studying. This is kind of their baseline status. Has anybody ever observed you to stop breathing during your sleep? I'll never forget back in the day when I was working EMS, we had a guy with horrible sleep apnea, and we had bunk beds in the firehouse. And if he slept on the top bunk, you would sit there and listen to him breathe, 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 stop. And it was like, you don't want to wake up with the dead guy in the bunk room. So you were waiting on him to start breathing again. Kind of rough, but we knew what was going on. He had sleep apnea. Other things we see, there tends to be a contribution for comorbidities. Sometimes it's tied into their BMI. So generally people with higher BMIs tend to have higher blood pressure, but not always. When I worked in Shreveport, our call room, everybody was in there together. And we had a guy who's a CRNA in East Texas now, was like 100 pounds dripping wet. And he was on a CPAP because he had horrible sleep apnea. But if you just looked at him, he didn't meet any of those criteria. Wasn't big, he wasn't old, he didn't have a big neck. He was male, but not a whole lot of kind of check boxes there, but he had bad sleep apnea. So moving on to the bang part of it. So BMI over 35, age over 50, increased neck circumference, and then, sorry, this one discriminates against the guys, male. So stop bang is something you'll see on your exam. It's something you'll see on boards. A lot of times we use this during our preoperative assessment of patients as well. Hypoxemia, we discussed, is one of the biggest problems we run into in PACU. So why does it happen? Sometimes patients need a little bit of extra oxygen as they wake up from general anesthesia. I realize that sounds crazy, but it's true. So if you have somebody after general anesthesia, put them on oxygen. It seems pretty straightforward, but sometimes it's not. You may also see that they're not breathing adequately. Well, why aren't they breathing adequately? Unfortunately, a lot of times we're to blame for this. Maybe we gave them too many opioids. Maybe we gave them too much Versed. Maybe they got too much Precedex. Any number of things can cause this. So just be mindful of that and make sure that your patients are not hypoventilating. Other things you'll see, those patients with sleep apnea. Lots of patients with sleep apnea still breathe, they just don't breathe adequately. So you'll see that they may take a deep breath and then they obstruct. So they're only breathing really about half of their normal respiratory rate. So we may need to consider waking them up. We may ultimately have to reverse the medications. So just be kind of cautious with that. We can also see what's called diffusion hypoxia. Again, this is a situation we create. So what happens is a lot of times we'll use nitrous oxide during our case, and at the back end of the case, as we start to wake people up, that nitrous oxide is going to rapidly diffuse out of the blood into the lungs. So we almost cause a hypoxia because that nitrous oxide is going to displace the true oxygen. The good news is it's very quick. It goes away very quickly. And it also does something we want because when it comes out of the blood, it's going to cause all those volatile anesthetics to come out with it. The downside is when it's doing that, it may cause hypoxia. Good news, easy to treat. We just have to make sure we're oxygenating the patient. So be very cautious if you have somebody that's been on nitrous oxide and then you either take them to room air or don't provide them enough time with oxygenation. How long does it go? It's very quick. Like I said, 5 to 10 minutes. So usually what will wind up happening if it's somebody that doesn't use nitrous oxide very often, we'll do what we call a nitrous wake up. So maybe the med student's taking forever to close, or this case is dragging on and on and on. Or maybe you had this person on a large amount of volatile anesthetics and you know that's going to take a while to come out of their tissue. So to kind of bridge that gap, we'll turn our nitrous or turn our volatile gas down, but we'll turn some nitrous on. Just be mindful as you do that it's going to take a little bit for the nitrous to come out. Certainly not as long as it would for the volatile anesthetics to come out, but you want to make sure your patient doesn't wind up hypoxic on the back end. Any questions on the respiratory stuff? Cool. All right, we're going to move on to circulatory complications. So we talked about systemic hypertension. You will see this after surgery. The treatment threshold really varies depending on the patient, but kind of the standard ones you'll see are a systolic blood pressure of 160, some places 180, or a diastolic blood pressure of 110 or 100. So what causes it? Sometimes they're excited on emergence. So think about somebody that's agitated, or maybe they're having a little emergence delirium. Other things you'll see that cause it, shivering. So if you have somebody that's shivering post-operatively, their blood pressure may not truly be high, but it's being measured as being high. So imagine if you had a patient that was having a seizure. You're not going to get an accurate blood pressure on that patient, right? But just like the other day where we were talking about temperature measurements, you may see that that kind of same lowest common denominator of how you're measuring things is what's being used for the blood pressure. So rather than adjusting the cuff or getting the patient to stop seizing, they just keep pushing the random number generator, and that's what they're getting for blood pressure. So they don't call you because the patient's shivering, they call because the blood pressure is high. So that may be a thought. Hypercapnia may be the cause of it. So if you have somebody that's maybe hypoventilating or obstructing, you may see that as their CO2 starts to climb, that their blood pressure goes with it. The most common one we think about is pain. But like I said, there can be other things that cause it as well. So usually we just kind of work through this differential list. Other things that can cause it, bowel distension, and it may be bowel distension or it may also be abdominal distension. So if you have somebody that had a laparoscopic procedure done and they insufflated, they may have some pain in their abdomen from all that gas that's in there. And then I already kind of talked about urinary retention. So where do we worry about the blood pressure? Part of it depends on the patient. Part of it depends on the surgical procedure. So lots of times if we have something where the surgeon's concerned about their blood pressure or their vascular status, they're going to lay out parameters for you. And what I mean by this is maybe this is somebody that just had a carotid endarterectomy done. and the surgeon doesn't want their blood pressure over 140 because he doesn't want them to bleed. Or maybe this is somebody that we're concerned about spinal cord syndrome, so we have them on a norepinephrine drip. Those patients, we may actually drive their blood pressure up. But then the nurse sees it and she doesn't understand what's going on, so she's trying to bring the blood pressure down. So sometimes you have to kind of explain things as you work through it. Usually, the way to treat this is going to be the underlying cause. So take care of their pain, get them calmed down, get them to stop shivering. And if not, then we're going to kind of consider our rapid acting medications. Our go-to for most hypertension is labetalol, and usually we'll dose it in 5 milligram doses and repeat it like every 5 or 10 minutes up to like 20 or 40 milligrams. So if I have somebody that's hypertensive and tachycardic, labetalol is kind of my go-to drug for that. If I have somebody that's not necessarily bradycardic, but heart rate's like 60s, kind of on the lower end, but they're also hypertensive, I probably don't want to give an agent that's going to bring their heart rate down any lower. So those patients, our go-to is hydralazine. Usually what we'll do as far as the hydralazine dosing is 5 to 10 milligrams, repeat every 20 to 30 minutes. Be very cautious when you're using hydralazine versus labetalol because the onset's a lot longer. So before you give another dose, make sure that that first dose has had enough time to work. Some patients use metoprolol. Usually if we're using metoprolol, it's patients that are already on a beta blocker preoperatively, and we're just trying to kind of follow up with that. With low pressure, remember you can always give more, but you can't take it away. So even though we don't commonly use this as an antihypertensive or kind of in the same dosing scheme as patients are normally on, I may just give them a milligram or two and then repeat it as opposed to giving 5 milligrams, which is kind of our common experience with other things. So going from one end to the other, we had hypertension. Now we have hypotension. Usually we can kind of classify this according to three things. The most common one we see by far is hypovolemic. So whether we got behind on fluid or we didn't realize that they'd had as much blood loss as they had or that their MPO deficit was as bad as we thought it was. For some reason, they've got a decreased volume, which is going to result in decreased preload. We may also see that it's a distributive problem. So maybe somebody's having an anaphylactic event. Maybe this is a patient with a spinal cord issue. So they've got decreased afterload. So you've got that same volume in the tank, but the tank just got a lot bigger. Or this may be a cardiogenic problem. So that patient that had the intraoperative MI, but they didn't have any EKG changes. They can't tell us that they're having chest pain. So those patients, it may be a pump problem. We may have to address it, not necessarily with volume, but with some sort of vasoactive medication. So what causes that decreased preload? It can be a couple things. Like I said, inadequate volume replacement. We may have replaced the patient with an appropriate amount of volume, but maybe it was all crystalloid and now they've third spaced it. So instead of having intravascular volume, now they've got a whole lot of tissue edema. You may see that it's a relative hypovolemia. This is almost like a distributive problem. So if I have somebody that I give a spinal anesthetic to, same thing. They've got the same amount of volume there, but their tank just got a lot bigger. So they've lost that sympathetic tone. Or this is somebody that's continuing to bleed. So you'll see the patients do fine, and then they've been in recovery for 30 minutes and they're noticing their blood pressure is trending down. And they call you and you go over there and you look at their JPs or their wound vac and you notice that it's full of blood. So anytime you see those things kind of going on, just be cautious and work through it that way. From a distributive standpoint, as I said, you may see it's due to sympathectomy, but commonly what we'll see is patients become either septic or they have like a delayed allergic reaction. So the ones you'll see that I really worry about with sepsis, and it tends to be very pronounced, are patients that become uroseptic. Some of the easiest cases you'll do are cystos. Commonly, we'll go through and do a cysto. They'll put stents in. Sometimes they do lithotripsy. But depending on what's going on with the patient and the degree of their disease process, they may have quite literal pus that's been blocked up in a kidney by a stone. And when they go through and put that stent in the ureter, or they break up that stone, all that pus is going to go systemic. And you will see that they quickly become hypotensive, tachycardic, because of that huge viral load or that huge bacterial load they just experienced. Sometimes these patients will wind up having to go to the ICU. Sometimes you'll be pushing epinephrine, vasopressin. So just a caution to you, if you're doing a cysto, even though it seems like a very basic case, make sure you've got some pretty heavy duty vasopressors available because of that. Other things to think about with really critically ill patients, you can see that small doses of anesthetic agents have a very exaggerated effect. So, for instance, if I take somebody who has a poor EF or a septic or they're volume depleted, and I give them what should be an appropriate dose of propofol or even a etomidate sometimes, you may see that it's got a very exaggerated effect. And what you see is that a lot of these patients are really relying on their sympathetic tone to keep their heart rate and blood pressure up. And when you basically give them a chemical sympathectomy with those medications, it takes care of that heart rate and that blood pressure, so they're not able to compensate anymore. So just be very cautious with those patients. In terms of allergic reactions, usually we have two different kinds that we'll see: anaphylactic and anaphylactoid. Epinephrine is going to be our drug of choice to treat hypotension if you've got an allergic reaction. So we'll use other medications to treat it, but epinephrine is really the go-to. The Benadryl, the steroids, a lot of those are not necessarily treating the reaction as they are some of the symptoms. What's the most common class of medications that causes allergic reactions? It's muscle relaxants, and with that, rocuronium tends to be the one that causes the most allergic reactions. So I know a lot of times we think about antibiotics causing it, but muscle relaxants is our most common. After that, you'll see that it's usually like natural rubber products. So think about patients with like spinal bifida. A lot of times they'll also be allergic to rubber or latex. Another common classification is healthcare workers because we had repeated exposures to latex. After that, it's antibiotics and then kind of some normal things. But those are really the big three you see are muscle relaxants, latex, and antibiotics. I don't know why it keeps going back to this slide. So just touching on the neuromuscular blockers, because they do cause it, what you're going to see in these patients, because the histamine releases, they become vasodilated, they become red, they become hypotensive. You may notice some edema, though it generally takes a couple minutes to happen. They're going to become tachycardic. The other thing you'll see, all these are great, but if you have somebody that's under anesthesia, like hopefully your patient you just gave a neuromuscular blocker is, you may not notice any of these things. So the only symptoms you may see are the hemodynamic ones. So they become tachycardic, they become hypotensive, and then when you look at their airway pressures, you notice that they've gone up. So just be mindful of things like that because they're not quite as apparent as you would think they are. So as I said with the latex allergies, it's generally going to be in high risk groups. So like I said, us, people that have been exposed to multiple surgical procedures, and then patients with spinal bifida. Usually it's kind of limited to like a contact dermatitis, but you may see that there's more impressive reactions as well. But it's generally pretty straightforward. As far as antibiotics, penicillin tends to be the most common triggering agent. Vancomycin gets blamed for allergic reactions, but it's not really the allergic reaction. It's more of that red man syndrome that we think about that causes like a direct histamine release. It's not allergy mediated. How does it manifest? Kind of the same way, but usually it tends to be more skin oriented as well. Pruritus, flushing, urticaria. You may see some angioedema if it's allowed to progress, and ultimately bronchospasm, hypotension, and death. Um, doesn't happen nearly as often as you would think it would. And usually, if it does, like I said, it's just going to be a little bit of redness. And the way it'll kind of manifest, we don't even notice it a lot of the times until we get to recovery and we're assessing the patient, or the case is over and we're taking the drapes down and we realize their chest is a little red or blotchy. Generally, outside of that, you don't have any signs or symptoms. So I talked about sepsis and kind of the high risk that we run into with urinary tract procedures. You can also see it with biliary tract procedures, general treatment, fluid resuscitation, and then pressure support. On the cardiac side, if we see this happen, from our perspective, it's usually going to be due to myocardial ischemia. You may see it occurring with dysrhythmias, but those generally present with the dysrhythmia, and then you figure out that you've got the cardiogenic failure. Um, and then patients with cardiac tamponade will experience this as well, but for different reasons. And generally, those aren't surprise patients as well. Very rarely do we have somebody that just magically winds up with tamponade. It's usually a polytrauma patient or somebody we know had a pericardial effusion. So we're not surprised by it. The ones that we see that develop are the ones that go into myocardial ischemia. So make sure you're utilizing the risk stratification for non-cardiac surgery just to figure out who's high risk for cardiac procedures. So how do we monitor myocardial ischemia? Continuous monitoring of the patient, and I say in the PACU because this is one of those areas that we tend to skimp on things. So you'll have patients that you do a great job of monitoring in the operating room, and then you take them to recovery and they don't get monitored quite as well. So especially in kind of those office-based settings or plastics, dental stuff. So make sure that they're still getting some sort of cardiac monitoring, especially those patients that are elevated RCRI. In a perfect world, you'd be able to have lead 2 and lead V5 with computerized ST segment analysis. But it doesn't always work out that way. Sometimes you just have 3 lead monitoring capability. So just be mindful that you're not able to assess everything with just those 3 leads. If you have somebody that you think is having an ischemic event, have a very low threshold for getting a 12-lead EKG, getting serum troponin levels, and then talking to the hospitalist about bringing him in for a day or so they can monitor him. So how do we treat MIs? The biggest part is avoiding things that cause it. So don't decrease your oxygen supply. Avoid tachycardia, avoid decreased oxygen content, avoid decreased coronary blood flow. If we can do all those things, even in somebody that's high risk, we generally won't have problems. But a lot of times when you do have an event, you'll go back and look and you can figure out where things went bad. Maybe you didn't give the patient enough sedation when you induced them and they had a period of tachycardia and hypertension. As a result of that, they didn't get adequate coronary blood flow. Or maybe you didn't pre-oxygenate this patient very well and they weren't able to tolerate that minute or two while you were getting your airway secured. So a lot of times, like I said, we can go figure out what caused it. And if we can prevent it, we don't have to worry about it. So what causes cardiac dysrhythmias? I talked about the guy that had the underlying history of dysrhythmias, but the big things you'll see that cause those dysrhythmias are hypoxemia. So us not adequately pre-oxygenating the patient, or maybe taking too long to try and get them intubated. Sometimes you'll see it's just like that patient I was describing. They have a catecholamine surge. So maybe we were worried about tanking their blood pressure, so we didn't want to give them a whole lot of sedation when we intubated them. But instead, we didn't sedate them adequately, and next thing you know, they had a period of tachycardia. You can also have electrolyte abnormalities that cause it. So just keep an eye on your patient's electrolytes, especially be mindful of potassium levels. You may see that because they're anemic, they don't have adequate oxygen carrying capacity. So as a result of that, they remain kind of persistently tachycardic. Or maybe they're in fluid overload, so their body's trying to get that fluid out of there, so it's pumping a little bit faster. Things like that, you just have to be very cautious with. Sometimes, like I said, they're a little bit easier to figure out after the fact than when they were actually going on. I put sinus tachycardia in here because it's really the most common perioperative arrhythmia we see. It can be caused by lots of things. We just talked about most of them. But the big ones we see are the volume status causes that are increased stimulation. So if we can keep an eye on bleeding, we can make sure our patients are comfortable. Generally, you don't have to worry about this quite as much. There's also more sinister things that can cause it, like pulmonary embolus, thyroid storm. But the most common we see, like I said, are volume and sympathetic stimulation. You'll also see that atrial dysrhythmias happen. Usually it's going to be after some sort of cardiac or thoracic surgery. Again, risk factors, patients with pre-existing cardiac disease, patients that are fluid overloaded, electrolyte abnormalities, or oxygen desaturation. So one of the problems we run into is patients that either we find an AFib that we don't know if they have a history of AFib or not, or they acutely go into AFib. So then we have to decide what to do with it. And the big determining factor there is determining the kind of onset time. Is this an existing arrhythmia or is this something new? If this is something new, then we probably want to go ahead and try and get them out of it as quickly as possible. If it's not new or we're not sure really the duration of it, you have to be cautious because if you try and restore them to their normal rhythm, You may notice that all of a sudden your patient dies because they've got a whole atria full of clots that you just kicked loose. So what we'll do with those patients a lot of times is do rate control and then get them a TE to figure out if they've got an atria full of clots. And then they may go ahead and cardiovert them at that time. So just a note on that, you'll notice that a lot of times we do what we call a TE cardioversion. So these people are in AFib, but we're not sure the duration of it. So we'll take them over there, we'll sedate them for the TE, and then they'll cardiovert them if they're able to. As far as treatment for AFib to get rate control, usually we're going to use either beta blockers or calcium channel blockers. I think cardizem is probably the most common agent we use, but it really depends on your comfort level. Some places still use verapamil. On the ventricular side, really all we see from ventricular stuff is PVCs, and usually the PVCs are due to a combination of underlying cardiac pathology and then a little bit of hypoxia. So if you start seeing PVCs, especially a large number of them, kind of work through the H's and T's, just like you would for somebody with cardiac arrest, because it's usually a lot of those same causes. Like I said, hypoxia is one of the most common ones, and then electrolyte abnormalities are another common one. Bradydysrhythmias, lots of things can cause it. The biggest one we see that causes it is us with inadequate oxygenation. You may also see it's due to elevated intracranial pressure or intraocular pressure, so be careful with kids and adults as far as like pushing on their eyes, stuff like that. It may be due to bowel distension, and sometimes our spinal anesthetics that'll cause it as well. When you cause that sympathetic blockade, you may notice that they become profoundly bradycardic. You may also see that it's due to a high spinal. So if you give a local anesthetic and it gets up to about T1 to T4 level, you're going to block those cardiac accelerator fibers. And when you do that, they're going to have profound bradycardia. You may notice that if you have somebody that's already had a sympathectomy because of a spinal, and then they become bradycardic and you weren't able to get adequate volume status in there, they are going to quickly go into cardiac arrest, even in young people. So just be very cautious with that. As a result of that, if we have anybody that we're concerned about their cardiovascular status, or even healthy people, we tend to give them a kind of a co-load of fluid. So we'll give them a fluid bolus before or during placement of that neuraxial anesthetic. So this is a newer area that we haven't really focused on too much in the past, but we're starting to recognize, especially in our elderly patient, the role of anesthetics in postoperative cognitive dysfunction. So when we think about this, the first thing that really comes to mind is delirium, but there's a lot more to it than just delirium. And when we think about delirium, this is like the people that we consider far off of their baseline. Usually we see it in the ICU, but it may have onset as early as in Pacu, or this may be somebody that even goes home and the family calls because they're acting weird and they have been right at surgery. Because of the anesthetic, sometimes we're not able to recognize it in the recovery room. But depending on how long the patient's there, and then, like I said, whether they go home or go into the hospital somewhere, we may get a phone call to evaluate it there. So who's kind of high risk for postoperative cognitive dysfunction? Older patients. And this is like really older patients. I'm not talking about, 50 where you can get your free cup of coffee. This is like 70 plus. If you have somebody with cognitive impairment before anesthesia, it's not going to magically make it better. It's probably only going to make it worse. Patients with decreased functional status, so maybe they have Alzheimer's, they're not able to do much around the house, they're bedridden. They lose a lot of those context clues at that point because they don't have kind of the normalization. Just like we would see patients in the ICUs that would do sundowning and stuff like that, when you lose kind of those reference clues, it makes things like this worse. And then patients with a history of alcohol or substance abuse are also high risk. So from an kind of intraoperative standpoint, what contributes to it? Patients with large blood volume losses. So if you have somebody that you have to transfuse multiple times, they're at elevated risk. Periods of hypotension tend to be associated with cognitive dysfunction. The administration of nitrous oxide and volatile agents can as well. So a lot of times what we'll try and do for these patients is a regional or a neuraxial blockade. And then if we're not able to do that, we may consider doing something like a propofol-based TIVA for those patients. So how do we manage it? First thing is figuring out who's high risk before surgery, because we may be able to alter our anesthetic plan for it. If you have somebody that's severely agitated ahead of time, kind of figure out a little bit different PACU plan for those patients. They may need like a one-on-one, they may need a sitter. Um, so just kind of know going into it. The other thing you want to think about, and it seems kind of counterintuitive, if you have an elderly patient that's having a kind of a basic surgery, you want to try and get them in and out of the hospital as possible. So even though you have maybe less resources, specialty hospitals or like day surgery centers tend to do a better job of getting patients in and out quickly. And that tends to reduce their incidence of postoperative delirium. So it may seem kind of counterintuitive to send them to the surgery center, but they may do better because they get in and out while they're there. So other things to think about as far as kind of like neurological problems, delayed awakening. So figure out why. Take a look at their vital signs. Think about problem areas. Is this somebody that's in pain? Is this somebody that maybe has continual or residual neuromuscular blockade? If you have somebody that is hypercapnic, it will cause sedation. So lots of places have gone to continuous end-tidal CO2 monitoring in the PACU or for sedated patients. So that may be helpful as well. Get a neurologic exam on them. Figure out, or can they talk to you? Can they move things? Is this somebody we're worried about them having a stroke? Is this somebody that, one of the big things we worry about is maybe they became hypoglycemic intraoperatively. So think about quick things you can do. Get an I-stat, get a blood glucose, things like that. Are they hypoxic? Is that why they're not waking up? So the number one cause, and it kind of makes sense, is residual sedation. So a lot of times what we'll do is try and treat those sedations that we can reverse. Benzodiazepines, we're going to treat with flumazenil. Opioids, we treat with Narcan. And we do very low dosages for both these medications. If you give too much flumazenil, it can cause seizures. Too much Narcan can also cause seizures, tachycardia, agitation. And you have to think about it from this standpoint. The patient just had something painful done to them. We gave them medication to control their pain, and then I give them a medication that blocks those receptors. So if I can titrate the Narcan to their respiratory status or their mental status, that's probably better than me coming in and giving them some huge 2 milligram bolus of Narcan that's blocked all those receptors, because now they're back in pain and they're agitated for another reason. We don't use scopolamine quite as often as we used to. We used to use IV scopolamine as a sedative in unstable patients, but we'll still use scopolamine patches a lot of times as an antiemetic. Personally, I'm not a big fan of them. Part of it is due to timing. Usually, if we're going to use a scope patch, it needs to go on hours in advance for it to work. So when we put a scope patch on somebody as we're rolling into the operating room, it's probably not going to help them out for hours. But what it will do is cause some CNS effects, especially in older patients. So be very cautious using scope patches. Even though it seems like something pretty basic, it can cause a lot of problems for you. Cold patients don't wake up nearly as well as warm patients, so try and keep your patients normothermic. We touched on hypoglycemia before. If you have any reason to believe somebody may be diabetic, or if they're just altered afterwards, always get a blood sugar. Other things we worry about, maybe they had some sort of intracranial event during their time in the operating room, whether it be elevated ICP or perhaps they've had a stroke. So sometimes after we've kind of gone through the common decision tree, we've reversed everything we could. We've made sure they're not blockaded. We'll go ahead and get a head CT because we're concerned they may have had a stroke. So this is kind of an overall recommendation of what a patient should look like when they're getting ready to leave the PACU. So you want them awake and oriented. If they weren't awake and oriented to start off with, you want them back to whatever their baseline was. There's not a mandatory stay time lots of places. It's not like you have to be in PACU for 5 hours. But generally, you'll see that it's at least a minimum of an hour, usually 30 minutes in phase one, 30 minutes in phase two. You want their vital signs to be stable. They've got to meet whatever the facility criteria is. So whatever your scoring system, that facility uses. A long time ago, we used to say that everybody had to pee before they left and they had to be able to drink and keep fluids down. We've backed off of that a little bit, but at the same time, you have to be cautious. I don't want somebody having to come back 2 hours later because they're not able to void. Or same thing, they weren't able to eat or drink because they were nauseated, and now we sent them out even though we knew that they couldn't keep liquids down. So you don't necessarily have to have that criteria, but it's something you probably want to suggest. Other things to think about, where are they going and who's going with them. We're trying not to send people home in Ubers. Some places, people don't drive anymore. They don't have cars. So it may be dependent on an Uber, but you want to make sure that there's an adult there. The Uber guy doesn't want to be having to carry these people upstairs when they get home. I have canceled cases before because there was not a safe place for that person to go or somebody to take them with them. Sometimes they'll even bring the kids to the hospital with them, which is an even worse situation. You're not leaving your kid in the waiting room while you go have surgery. So just be mindful of things like that. It doesn't seem like something you should have to worry about, but it is something that may be a reason to avoid having anesthesia. Again, this is kind of back to that criteria as far as being released from the PACU. That probably looks familiar to you. And that's it. These are a couple of resources for you if you want kind of some follow-ups of stuff. There's lots of handoffs and kind of go-to guides for people out there. Just figure out what you like best or what the facility uses. There's definitely plenty of resources out there. Questions. Omar asked, would scleroderma predispose a patient to airway edema given the collagen deposit excess? That makes sense to me. I know a lot of times that they'll be likely to have narrowing and compression of the airway, but I don't know specifically. I would have to look that up. The last table that was on there is very similar to the Aldrate score you saw before. All right, what other questions do you guys have? Caitlin asked about cool happy hours at Texana. So if you're going this weekend, I don't know if you guys saw the schedule. I think they sent it out in an email yesterday. Kind of some goings on. And I'll just run through the schedule for the weekend with you guys. Tomorrow at 5 o'clock is a welcome reception in one of the, I think it's like the Regency Ballroom or something. After that is the College Bowl. And then I think, let me find the schedule before I tell you wrong, but I'm pretty sure there's a reception after the College Bowl as well. So there's a welcome reception, the College Bowl, and then a reception after that. So those are fun. There's also, I mean, it's in a hotel, so there's plenty of places around there. I'm sure there's a bar in the hotel. For Saturday, there's the awards gala that evening, but there's also usually like a meet and greet with vendors during the evening before that. I would encourage you guys, if you're going to go to the business meeting, I think it's important for you guys to understand what's really going on in the state and kind of where things are coming or going. And then I think that's really the big things as far as like get-togethers for the weekend. Anybody have any other questions? Vlad asked if patients go from phase 2 back to phase 1 or to ICU if they develop complications. It really depends on the facility. Some places phase 2 is physically different than phase 1. Some places they stay the same place, but the staffing ratio will change. So it's not necessarily a big issue. I'll also tell you that the PACU nurses are pretty careful about making sure it's a one-way street. So if it's somebody they're not sure about, very rarely are they going to go on to phase 2. Now it could happen. I mean, just like somebody walking down the street could have a heart attack, it could happen there too. But they can usually get them back to PACU or get them up to the ICU, either one, depending on where they're headed. If it's something short term that they should be able to manage in PACU, they'll go that route. If it's something that they need to be admitted for, they may go to ICU. The other thing is the patient may stay in phase 2 and you'll go manage it there. So they may not have to physically change locations until it's really assessed, and then you kind of know where they're going.